Welcome to this medicine masterclass in which we will be reviewing the clotting cascade. Here is a representation of the coagulation clotting cascade. There are two key pathways, the intrinsic pathway and the extrinsic pathway. The intrinsic and extrinsic pathway both lead to the conversion of prothrombin to thrombin, which is involved in the conversion of fibrinogen to fibrin, which forms a cross-linked fibrin clot. The extrinsic pathway involves the activation of factor 7 to 7A, which activates 10 to 10A, which is used as a cofactor to drive the conversion of prothrombin to thrombin. The intrinsic pathway begins with factor 12, which becomes 12A, activating 11 to 11A, activating 9 to 9A, and that drives the conversion of factor 10 to 10A, which is used to drive the conversion of prothrombin to thrombin, which subsequently leads to the conversion of fibrinogen to fibrin and the cross-linked path. This common pathway of factor 10A requires factor 5 to cleave prothrombin into thrombin, and this is what leads to the fibrinogen being converted to fibrin, eventually causing the cross-linking and formation of a fibrin clot. While several factors drive the formation of a clot, there are important proteins which impede or prevent clot formation. These include antithrombin, protein C, thrombomodulin, protein S, as well as tissue factor pathway inhibitor, and these inhibit coagulation. Vitamin K plays an important role in the clotting cascade and is the target of warfarin. Factors 2, 7, 9 and 10 require carboxylation of their glutamic acid residues to allow these coagulation factors to be active. The enzyme that carries out this carboxylation process is gamma-glutamyl carboxylase. The carboxylation is dependent on the conversion of vitamin K hydroxyquinone, which is a reduced form, to vitamin K epoxide, the oxidized form. This oxidized form is recycled back by another enzyme called vitamin K epoxide reductase, or VCOR. Warfarin inhibits epoxide reductase, thereby diminishing available vitamin K, which inhibits the carboxylation activity of glutamyl carboxylase. When this occurs, those coagulation factors are no longer carboxylated and thus rendered biologically inactive. Over time, the previously produced active factors degrade and are replaced by inactive factors, and the anticoagulant effect becomes apparent and can be measured by measuring the INR, or the International Normalized Ratio. Importantly, when warfarin is newly started, it may promote clot formation temporarily. This is because the protein C and protein S are also dependent on vitamin K activity. These are natural anticoagulants, and these decline within the first 36 hours, and so during the instigation of warfarin therapy, patients have parenteral heparin administration. Thank you for attending this medicine masterclass.